This discussion is about ovarian tumors. In this video, I will discuss the different types of ovarian tumors and I will pass through the most important pathological and clinical points. So this video will be beneficial for you if you are studying pathology or gynecology. So, first, to understand the origin of the ovarian tumors, we must understand the histology first. The ovary is made up of three main components, as you can see in this picture. The most superficial part is the surface epithelium, and the deep to it we have the germ cells, the cells that will form the female gametes, the ova, and between these ova we have the sex cord stroma, this part which form the supportive part for the ova, which include the granulosa cells, the theca cells, and fibroblasts. So ovarian tumors can arise from each of these parts. So we have epithelial tumors, we have germ cell tumors, and we have sex cord tumors. First, we have the epithelial tumors. The epithelial tumors are actually the most common ovarian tumors. They make up to 75% of the ovarian tumors, and these tumors are derived from the coelomic epithelium. The coelomic epithelium is the epithelium which forms the fallopian tubes, the cervix, and the endometrium. So from this we can understand that we have different types of epithelial tumors. We have the serous type, which forms the fallopian tubes. We have the mucinous type, which forms the cervix, and we have the endometrioid type, which forms the endometrium. So we have an additional type which is called the Brenner tumor. The most common types are the serous and the mucinous tumors. These are actually a proliferation of the cells present in the ovary, whereas the Brenner tumor and endometrioid tumors are actually a metaplasia, in which the normal epithelium of the ovary changes into another type which will undergo a neoplastic transformation. So, the epithelial tumors, we have serous, mucinous, Brenner, and endometrioid tumors. Okay, let's start with the serous tumor. Serous tumors are the most common type of ovarian tumors, whether malignant or benign. The serous tumors are the most common. Ovarian tumors in general are also classified into three different degrees of malignancy, or of the way they behave. We have the benign tumors, we have the borderline, and the malignant tumor. The benign tumor is usually a cyst that is made up of a single layer, whereas the malignant tumor is a cyst made up of multiple layers and also can be solid. So serous tumors can be benign, borderline, in which the cells can undergo malignant transformation, but they don't have the same malignant potential as malignant tumors, but still they have the ability to transform into malignancy. And also serous tumors can be malignant. So the benign tumor is called serous cyst adenoma. The malignant is called serous cyst adenocarcinoma, because these tumors are usually cystic. Serous tumors also can be bilateral in a significant percent of patients, and the malignant types undergo dystrophic calcification, which result in the formation of what's called psammoma bodies. This is an important pathological point. The important clinical point with serous tumor is that they are highly associated with mutations in the BRCA gene. This gene, which is also involved in the pathogenesis of breast cancer, makes the patient susceptible for ovarian serous tumor, and also tumors of the fallopian tubes. That is why these patients who have mutations in the BRCA gene undergo prophylactic mastectomy and prophylactic salpingo-oophorectomy. So, next slide. This is a picture of malignant cystadeno of Serous cystadenocarcinoma, and you can see here the samoma bodies, which are foci of dystrophic calcification that result in calcium deposition. So this what we need to know about serous tumors. They are the most common type. They can be bilateral, they can be benign, borderline, or malignant. The malignant one contain samoma bodies, and the malignant one are also associated with the mutations in the BRCA gene. This is highly important. The next type is actually the mucinous tumors. Mucinous tumors, as I said earlier, are derived from the same epithelium that forms the cervix. We have two important clinical points with the mucinous tumors. First of all, these tumors can reach a very large size before being detected, and this may result in their rupture with seeding of the peritoneum. This is known as pseudomyxoma peritoneum. An ovarian tumor, which is a mucinous in type, gets enlarged and then rupture with seeding of the peritoneum. However, ovarian tumors are not the most common cause of pseudomyxoma peritonei. The most common cause is actually appendiceal tumor, a tumor of the appendix, with metastasis to the ovary. This is the usual picture with pseudomyxoma peritonei. Second point, which is a clinical point, mucinous tumors are radio and chemo resistant. This is important. And also, mucinous tumors need to be differentiated from metastases to the ovary, known as Krukenberg tumor, which I will discuss in the end of this discussion. Third type of surface epithelial tumors of the ovary is the endometrioid tumors. As the name suggests, these tumors are derived from the epithelium, from the same epithelium that forms the endometrium of the uterus. Usually malignant. These tumors are usually malignant. And there are two theories behind their development. The first one, which I said earlier, is metaplasia, in which the ovary undergoes metaplasia into endometrioid epithelium, which will undergo neoplastic transformation. However, the second theory, which is more accepted, is that when the female undergoes her menstrual period, there is backflow of the menstrual substance along the fallopian tubes into the ovary with implantation inside the ovary. This is known as endometriosis, which is the formation of endometrioid tissue outside the uterus or outside the endometrium. This is the cause of endometrioid tumor, endometriosis. And also 15% of patients with endometrioid tumor of the ovary, we have an isolated endometrial carcinoma. So this is very important. We must check the patient for endometrial carcinoma. The last type of surface epithelial tumor that I will discuss is known as the Brenner tumor. This tumor is important for only a single point. It contains a transitional epithelium, which is the same epithelium that forms the bladder, the urinary system, which is known as bothered cell rests. Brenner tumor contains a transitional epithelium. This is the only important point for us. We can see here, this is the transitional epithelium. We have these transitional cells with their large nuclei which form nests. This is seen in Brenner tumor. Okay, this is the first group of ovarian tumors, the surface epithelial tumors. The most common, as I said, are the serous and then the mucinous, and we have also the endometrioid and the Brenner. The next group is known as the germ cell tumors. The germ cells, as I said earlier, are the cells that will form the female gametes, the ova. And The way I remember these tumors is to try to imagine what the destiny of this ova, what this ova will give in the future. First, it can give fetal tissue. And the fetal tissues are made up, as we remember, of three layers: the ectoderm, the mesoderm, and the endoderm. So, a tumor that contains all these three layers is known as teratoma. So, an ova can give fetal tissue, which can give teratoma. Also, these cells will form another germ cells, another ova, and a tumor derived from these germ cells is known as Dysgerminoma. Okay. Also we have the placenta is derived from these cells, which will give us the Choriocarcinoma. And also, if we remember from the embryology, we have the yolk sac derived from these germ cells, and we have the yolk sac tumor. So germ cells will give us fetal tissue that will develop into teratoma. Germ cell will give us Dysgerminoma. Placenta will give Choriocarcinoma, and the yolk sac will give the yolk sac tumor. Now we will discuss briefly some points about these tumors. First, teratoma. Teratomas, I think they are the most important for us as students, because they have many pathological and clinical points. First of all, teratomas are mostly benign, and as I said, they contain tissues derived from all three germ layers that make up the embryo. So we can see here skin, hair, thyroid tissue, bone, muscle, nerves. Any type of tissue can be present in a teratoma. And teratoma are usually cystic. That is why it is called a cystic teratoma of the ovary. I said teratomas are usually benign. However, they can undergo malignancy in two ways, which is rare. First of all, if we have an immature tissue within this teratoma, this immature tissue can undergo malignancy, and the most common immature tissue is the neuroectoderm. The second way by which we can have a malignancy with teratoma is that these somatic tissues, the skin, the bone, themselves can undergo malignancy. And the most common type is the squamous cell carcinoma of the skin of teratoma. So teratoma by themselves are benign, but if they contain immature tissue, they can get malignant, and the somatic tissues within themselves may undergo malignancy. The second important point about teratoma is what is known as stroma ovarii, which is a teratoma containing thyroid tissue which present as thyrotoxicosis. Here a patient presents with signs and symptoms of thyrotoxicosis with an abdominal mass. When you check the abdominal mass by ultrasound, you see an ovarian mass, and this is stroma ovarii. This is very important. Teratoma can be bilateral in about 10% of cases. Okay. This is a picture, a gross picture of teratoma. We can see different types of tissues here: teeth, skin, hair, any type of tissue, and even bone, I think, is present here. And this is under the microscope. We can see keratinized epithelium of skin. We can see cartilage, cystic, glandular structure. Any tissue can be present within a teratoma. So, second type of germ cell tumors is the Dysgerminoma. Dysgerminoma is the most common germ cell tumor to undergo malignancy. This is important. The second important point is the tumor marker. The tumor marker of Dysgerminoma is LDH, and the Dysgerminoma is common in patients with Turner syndrome. So the patient may present with streak, what's known as streak genitalia, and with ovarian mass. This is the Dysgerminoma, and the tumor is chemo and radiosensitive. The male counterpart of Dysgerminoma is known as seminoma, which is a common testicular tumor in males. Third type, we have the yolk sac tumor. The yolk sac tumor is common in young female children, and actually it is the most common ovarian tumor in girls under 4 years of age. However, this is not the most common. This is not the most common age of presentation. It usually presents during the third decade, but still it is the most common ovarian tumor in children less than 4 years of age. Pathologically, it contains what's known as chiller duval bodies. These are actually immature glomeruli. We have structures like the glomeruli of the kidneys within the ovarian tumor. This is known as chiller duval bodies, and the tumor marker is alpha fetoprotein. This is important. It's the most common ovarian tumor in girls under 4, and it contains chiller duval bodies, and clinically we have alpha fetoprotein. This is the chiller duval body. We can see here this white space, which is the Bowman capsule, and this looks like an immature glomerulus. Fourth type of germ cell tumor is the choriocarcinoma. This is a tumor derived from a placental tissue, so it contains cyto and syncytiotrophoblasts. This tumor is usually malignant, and it secretes beta HCG, and this makes sense. It is a tumor of a placenta. So here we will have a patient presented with an enlarged abdomen, with an abdominal mass, and when you do a pregnancy test, you get a positive pregnancy test. So it is including the differential diagnosis of an abdominal enlargement plus positive pregnancy tests. This is choriocarcinoma. Third group of ovarian tumors is known as the sex cord tumors. As I said, the sex cord is the stroma of the ovary, and it contains the granulosa cells and the theca cells, along with other types like Sertoli and Leydig cells and fibrous cells. So we have 3 types of tumor cells. Here we have the granulosa cell tumor, we have the Sertoli Leydig cell tumor, and we have Fibroma. Granulosa cell tumor is a tumor that can be seen at any age. However, most patients are elderly. This tumor secretes estrogen, and this also makes sense, as we remember the function of the granulosa cell is to convert the androgens secreted by the theca cells into estrogen under the influence of LH. So this tumor secretes estrogen. So here, if we have a young patient, a child, this will present with homosexual precocious puberty. We have a female child who grows as a female but faster than her colleagues. And this is the important clinical point. And the important pathological point is it contains what's called as Kohl-Exner bodies. These are actually eosinophilic collections or depositions that are present within the tumor. These are the Kohl-Exner bodies. Okay. This tumor, as I said, present at any age, secrete estrogen. So in a child, it present as heterosexual precocious puberty. However, in elderly, which is the commonest age of presentation, it will present with signs of increased estrogen. So we will have postmenopausal bleeding and endometrial hyperplasia. And in a woman in her reproductive age, it will present with menorrhagia and menstrual irregularities. This is high yield. Second type is the fibroma. Fibroma of the ovary is important for only one point. It is associated with ascites and pleural effusion on the right side. This triad is known as the Meeks syndrome. We have benign fibroma of the ovary, ascites, and right-sided pleural effusion. This question is common in exams. Meeks syndrome. The last type is the Androblastoma, which is the same as the Sertoli Leydig cell tumor. This tumor secretes androgen. So a child here will present as heterosexual precocious puberty. A female child, genotype XX, will grow as a boy. It will develop the secondary sexual characteristics of males. In a child-bearing woman, this will present as hirsutism and virilization, which are the signs of hyperandrogenism. The second point is that this tumor is associated with Peutz-Jeghers syndrome, which is a syndrome of the GIT. We have discoloration of the oral cavity with polyps within the colon. It is associated with Androblastoma. Last thing is the metastasis, what is known as the Krukenberg tumor. A Krukenberg tumor is a metastasis of a mucinous tumor into the ovary. This tumor is usually bilateral, and as I said, it has a mucinous metastasis. And the most common primary site is the gastric cancer. The diffuse type gastric carcinoma will send metastasis to the ovary, known as Krukenberg tumor, which contains signet ring cells, which we will see in the next slide. This tumor needs to be differentiated from the primary mucinous tumor of the ovary, and the bilaterality of this tumor is actually the differentiating point, because the mucinous tumors of the ovary are usually unilateral. However, Krukenberg tumor are bilateral. This is the gross appearance of Krukenberg tumor. We can see it's bilateral, lobulated appearance, and this is what we see under the microscope. These known as the signet ring cells, in which the nuclei are deviated to the periphery of the cell because of increased amount of mucin within the cell. And I think that is all what you need to know about ovarian tumors. Thank you.